Hello everyone, my name is Dr. Rajiv. Welcome to my education channel, YouTube Surgery and Orthopedic Education. We shall today discuss metabolic response that takes place after trauma and surgery. At the end, please subscribe to our channel and give us a like if you find the lesson useful. So let us not waste time anymore and get set, go. During the initial hours or F phase after surgical or traumatic injury, not all tissues are catabolic. Several key elements of the flow phase determine the extent of catabolism after trauma. The body reprioritizes protein metabolism from peripheral tissues like skeletal muscles, adipose tissues, and skin to key central tissues such as liver, immune system, and wounds. There is irreversible degradation of branched-chain amino acids leucine, isoleucine, and valine, and increased efflux of glutamine and alanine from the skeletal muscles. Glutamine and alanine, thus derived from muscle proteolysis, are reutilized in the liver to form acute-phase proteins. There is a reduced total body energy expenditure and urinary nitrogen wasting. On adequate resuscitation and stabilization of the injured patient, a reprioritization of substrate use begins to support the repair of injured tissue. This phase of recovery is also characterized by increased metabolic rates, increased oxygen consumption, preference for readily oxidizable substrates such as glucose, and a stimulation of the immune system. The process can be summarized as hypermetabolism, changes in skeletal muscle protein metabolism, changes in hepatic protein metabolism, insulin resistance, and changes in lipid metabolism. Hypermetabolism. Traumatic stress induces a hypermetabolic state of increased metabolic rate and increased urinary nitrogen loss. Hypermetabolism is commonly seen in people with post-surgery or traumatic injury, severe burns, and sepsis during recovery. The main purpose of this response is the mobilization of amino acids and the production of glucose to provide energy for the cells involved in the host immune response and wound repair. The cortisol, catecholamines, and glucagon hormones are largely responsible for these effects. Most trauma patients demonstrate energy expenditures approximately 15 to 25% above the predicted healthy resting values. In severe burns, this value may go up to 140%. Various mechanisms are involved in this hypermetabolic response, such as central thermodysregulation caused by the pro-inflammatory cytokines release, increased sympathetic activity due to catecholamine release, abnormalities in local wound circulation, either ischemia or hyperemia, increased acute phase protein synthesis, and nutritional support. All these may increase patient energy expenditure. Thus, the main cause of hypermetabolism following injury is the acceleration of energy-dependent metabolic cycles. In modern critical care practice, the elements of a standard intensive care, including bed rest, paralysis, ventilation, and external temperature regulation, ameliorate hypermetabolic stress response. If the injury is severe and prolonged enough, there is a skeletal muscle wasting which limits the volume of metabolically active tissue. This cachectic response is mediated at the molecular level by activation of the ubiquitin proteasome pathway. If prolonged and excessive, this may result in immobility, hypostatic pneumonia, and death. Hence, the primary goal of glucose administration in surgical patients is to minimize muscle wasting. Changes in muscle protein metabolism. In normal conditions in humans, there is continuous synthesis as well as a breakdown of muscle protein. The normal turnover rate of muscle protein catabolism in resting conditions is 1 to 2% per day. Under normal resting conditions, protein synthesis equals breakdown and the muscle mass remains constant. Feeding and exercise are physiological stimuli that promote net muscle protein buildup. But during exercise, skeletal muscle protein synthesis decreases while it increases again during rest and feeding. During the catabolic flow phase of the stress response, there is an increase in muscle protein degradation and a decrease in muscle protein synthesis, leading to muscle wasting. Peripheral skeletal muscles, respiratory muscles, and gut muscles are the major sites of such protein loss. Cardiac muscle is mostly preserved. The clinical effects of these changes are hypoventilation and chest infections as well as reduced gut motility. If the trauma and sepsis are severe and prolonged, extreme conditions of catabolism follow, with urinary nitrogen wasting reaching up to 14 to 20 grams per day, which is equivalent to the loss of 500 grams of skeletal muscle per day. It is noteworthy that as long as the stressor and the stress response continue, the muscle breakdown cannot be halted fully by providing artificial nutrition support. Studies reveal that aggressive artificial nutrition support or hyperalimentation works as a metabolic stressor itself. Therefore, the nutritional support should be modest with a view to ameliorating rather than replacing energy and protein losses. A skeletal muscle wasting causes asthenia or loss of energy, increasing fatigue, reduced functional capacity, low quality of life, and increases the risk of morbidity and mortality or death. Critical illness myopathy or CIM. Critical illness myopathy is one of the two distinct clinical entities, the critical illness polyneuropathy and the critical illness myopathy, which affects more than one third of the most severely critically ill patients. Their magnitude is associated with the development of acute respiratory distress syndrome, sepsis, or systemic inflammatory response syndrome. CIM is characterized by the selective loss of myosin causing myofiber atrophy and death. It is a multifactorial condition that occurs due to impaired excitation contraction coupling at the sarcoplasmic reticulum membrane. Some underlying causes have been identified, such as systemic inflammation, prolonged immobilization, and microvascular vasodilatation and increased permeability. Ubiquitin proteasome pathway UPP. A skeletal muscle wasting is a debilitating condition that commonly occurs as a secondary consequence of many acute and chronic medical conditions, including severe trauma, critical illness, cancer, and aging. Several mechanisms are involved in skeletal muscle wasting due to protein degradation. The two major protein degradation pathways are the UPP, ubiquitin proteasome pathway, and the autophagy lysosome pathway. But the predominant mechanism is the UPP or ubiquitin proteasome pathway. This response is facilitated by tissue hypoxia, acidosis, insulin resistance, and elevated glucocorticoid levels. It is an energy-consuming ATP-dependent pathway facilitated by the lysosomal cathepsins and the calcium-calpain pathway. In this pathway, there is the degradation of myofibrillar or muscle proteins into free amino acids. The ubiquitin proteasome pathway is a complex multi-step process which requires ATP and results in the tagging of specific proteins with ubiquitin for the degradation of the proteasome known as ubiquitination. The three enzymes involved in ubiquitination are E1 or ubiquitin activating enzyme, E or ubiquitin conjugating enzyme, and E3 or ubiquitin ligase. Changes in liver protein metabolism. The liver and skeletal muscle participate in more than 50% of daily body protein turnover. The liver has a smaller mass, which is 1.5 kg, but a greater protein turnover rate than the skeletal muscle, which is 10 to 20% per day. The major export protein produced by the liver is albumin and its renewal rate is about 10% per day. The transcapillary escape rate or TER of albumin is about 10 times its rate of synthesis, and it may increase threefold following major injury or sepsis. In inflammatory conditions such as surgery, trauma, sepsis, cancer, or autoimmune diseases, there is secretion of pro-inflammatory cytokines, interleukin 1, interleukin 6, and tumor necrotic factor alpha. These cytokines, particularly interleukin 6, induce the synthesis of positive acute phase proteins such as C-reactive protein or CRP, ceruloplasmin, and fibrinogen by the liver. On the other hand, there is an acute fall in the plasma concentrations of other liver export proteins or the negative acute phase reactants, for example, albumin and transferrin. But the increased hepatic synthesis of positive acute phase reactants is not compensated for by the reduced synthesis of negative reactants. The reason is that the fall in plasma concentration of negative acute phase reactants is due principally to the increased transcapillary leakage secondary to increased microvascular permeability. The net changes in protein catabolism and synthesis correspond to the severity and duration of the injury. Elective operations and minor injuries result in lower protein synthesis and moderate protein breakdown. Severe trauma, burns, and sepsis are associated with increased protein catabolism. The rise in urinary nitrogen and negative nitrogen balance is detected early after injury and peaks by 7 days. This state of protein catabolism may persist for 3 to 7 weeks. Insulin resistance after trauma. After surgery, trauma, and severe infections, there is an increased glucose production together with decreased glucose uptake in peripheral tissues, resulting in a state of peripheral glucose intolerance and insulin resistance, despite ample or even elevated insulin production. This occurs due to reduced skeletal muscle pyruvate dehydrogenase activity after injury, which suppresses the conversion of pyruvate to acetyl coenzyme A and its entry into the Krebs or TCA cycle. The three carbon substrates such as pyruvate and lactate accumulate and are shunted to the liver for gluconeogenesis. The liver gluconeogenesis arises primarily from alanine and glutamine catabolism and provides a ready fuel source for the nervous system wounds and erythrocytes which do not require insulin for glucose transport. The final common pathway of the metabolic response to post-traumatic stress is uncontrolled catabolism and the development of resistance to anabolic signals, including insulin, in order to prioritize the delivery of energy substance to vital tissues such as the liver and kidneys over the insulin-dependent organs, mainly fat and muscle. Therefore, insulin resistance is considered an adaptive mechanism designed to provide a sufficient amount of glucose to the vital organs and to reduce insulin-mediated glucose uptake in the periphery. The magnitude of this insulin resistance is proportional to the severity of the condition. Insulin resistance results from the action of pro-inflammatory cytokines and from decreased responsiveness of the insulin-regulated glucose transporter proteins such as glucose transporter 4 or GLUT4. Following an upper abdominal surgery, the state of insulin resistance may persist for up to 2 weeks. Post-operative patients with insulin resistance are like individuals with type 2 diabetes mellitus. The management of insulin resistance is intravenous insulin administration. Changes in lipid metabolism after trauma. Lipids are essential for the structural integrity of cell membranes as well as the immune response during systemic inflammation. Triglycerides provide 50 to 80% of the energy utilized after trauma and critical illness. Lipolysis is accelerated during the early ebb phase of metabolic response because of the induced post-inflammatory neuroendocrine response. Hormones that accelerate lipolysis include increased levels of adrenocorticotropic hormone or ACTH, catecholamines, thyroid hormone, cortisol, glucagon, growth hormone, and reduced insulin levels. Since glucose is only partially oxidized, 80 to 90% of the energy required for gluconeogenesis is derived from fat oxidation. During ebb phase, plasma fatty acid and glycerol levels are increased by lipolysis.